recording now. So here we go. All right. So the session, as we said, is being moderated by Dr. Erika Crable. Dr. Crable's postdoctoral scholar here at UCSD and integral to our Dissemination Implementation Science Center. She brings with her experience in policy, both from a very applied perspective, having worked for IBM Watson and the Center for Medicaid Services here in the US before earning her PhD from Boston University in policy around Medicaid and addiction. So with that, I will turn it over to Erika. Thanks for taking the lead here, Erika.
Thanks so much, Dr. Ahrens, and thank you all for joining us today for our second Health Policy Dissemination and Implementation Science Seminar. For those of you who are joining us for the first time, we are using this seminar series to explore the utility of dissemination and implementation science approaches to examine policy development and implementation processes. So some of the utilities we spoke about in our prior seminar include using D&I science approaches to conduct a contextual assessment of the mechanisms and determinants that influence the use of research evidence in policy. So this could include things like identifying factors that mediate or moderate policymakers' use of evidence or the adoption of evidence-based policy, and identifying evidenced intermediaries who may improve the climate for evidence use. We can also test dissemination and implementation strategies that promote the adoption of evidence-based policy, advance D&I framework development to better understand how policies are developed, disseminated, and implemented, and measure the impact of evidence-based policy on population health outcomes. And so you might ask yourself, why are we doing this seminar series about policy? So within the implementation science field, policy has long been ignored or treated as sort of a background factor distally impacting implementation outcomes. But we know that this is not the whole picture. Nearly all policies have some impact on health, whether directly or through a social determinant of health like economic opportunity, housing, transportation, and work environments. So the goal of this seminar series is to learn from other disciplines like political science and public administration that have been focusing on policy development much longer, and to explore opportunities for policy to really be at the forefront of dissemination and implementation science research as the evidence-based practice thing that we aim to adopt, or as the strategy to facilitate the uptake of another evidence-based thing, or as a meaningful contextual determinant. So today we're featuring the research of 3 experts who have investigated policy D&I approaches related to COVID-19 policies. And we're aiming to generate a conversation around the use of health policy dissemination and implementation sciences for advancing health equity goals, around strategies that might be needed to build trust in evidence-based vaccines or therapeutics. And we'll also think about strategies to enhance the use of research evidence by systems and organizational policymakers, because as we know, policy happens across multiple levels of big P's and little p policies. So today, I'll introduce all 3 panelists before they each give brief presentations, and then we'll have a good chunk of time for discussion. So as Greg said, please do put your questions into the Q&A function as they come up. You can use the chat to introduce yourself and to just sort of add reflections or comments on the discussion from our presenters. I'll start by introducing Dr. Emmons. She's a professor of social and behavioral science at the Harvard T.H. Chan School of Public Health. She's a behavioral scientist whose work focuses on community-based approaches to design, evaluation, and implementation of cancer prevention interventions in settings that serve historically disadvantaged communities, including low-income housing and community health centers. She's the multi-PI of the P50 Implementation Science Center for Cancer Control Equity and the MPI of the study Rapid Acceleration of COVID Diagnostics in Vulnerable Populations in Massachusetts. She's also the MPI of Harvard's T32 Cancer Prevention Education Training Program. She currently serves as the faculty director of the Community Engagement Program for Harvard's Clinical Translational Science Award, and Dr. Emmons is the past president of the Society of Behavioral Medicine and a member of the National Academy of Medicine. Dr. Turner is also with us today. He's an associate professor and director of the organizations area in the School of Management at Universidad de los Andes in Bogota, Colombia. Prior to joining Los Andes, Simon was a senior lecturer in health policy and organization at the University of Manchester. He has held postdoctoral research positions at the University College London, King's College London, London School of Hygiene and Tropical Medicine, and University of Cambridge. His research interests lie in the application of social science theory and methods to study the organization and improvement of healthcare. He is a principal investigator of the nationally funded study on the coordination of change in response to COVID-19 within the Colombian health system. Dr. Lavis is also with us today. He is the founder and director of the McMaster Health Forum. He and the McMaster Health Forum are committed to helping policymakers and stakeholders learn how to make decisions based on the best available research evidence, find evidence through the forum's own products, which you'll learn about more today, and also use the best available sources of pre-appraised, synthesized research evidence. His work sparks action through stakeholder dialogues and citizen panels, embeds supports for evidence-informed decision-making, and evaluates innovations in supporting evidence-informed decision-making. Dr. Lavis is also co-lead of the COVID-19 Evidence Network to Support Decision-Making, aka COVID-END, and he is co-director of the World Health Organization Collaborating Center for Evidence-Informed Policy and professor in the Department of Health Evidence and Impact at McMaster University. A huge thank you to all of our incredibly accomplished thought leaders and researchers for joining us today. We are so delighted to learn from you. And without further ado, I will turn it over to Dr. Emmons to start us off.
Thanks so much. It's really wonderful to be here with you today. I'm really pleased and honored to be invited. Well, as Dr. Crable said, I'm a behavioral scientist, and I really spent my career focused on cancer disparities and developing interventions to ensure that we have effective cancer prevention and early detection approaches for historically marginalized and disadvantaged populations. I've been drawn to implementation science really from the early days for two reasons. First, I was getting really tired of developing interventions that were effective where we studied them. They were published, but they weren't used. They weren't maintained in the places we studied them, and they certainly weren't used in places that we didn't study that had different kinds of contexts, different kinds of settings. That was really pretty quickly getting to be a problem for me personally in terms of all the energy and resources we were putting into things that weren't being sustained. The other reason that IS has been really important to me is that as my career developed and I really based all of my work in community-based settings, we were finding that the characteristics of under-resourced communities really rendered many of the evidence-based interventions that were being developed unusable for a whole variety of reasons. The intensity of the intervention, the professional skills that were needed to deliver them, the language needs of the population that were in these communities that were trying to pick up these EBIs. And, you know, really, this all reflects the fact that in the field, we've made a lot of assumptions. And I think we historically have thought, you know, if we build it, they'll use it. And that's just not true. And so context becomes really important when we're thinking about intervention development, developing evidence, and how we move that evidence forward into whatever form it takes. For my own work, we've done a lot of work around engaging stakeholders and end users and really trying to partner with communities as effectively as possible to develop evidence that then can be sustained in those settings. And I would just argue that if we don't do that, it's at our own peril. This is a space we've been really trying to work in for a long time. So over the last few years, I've taken a step back and thought a lot about context and how it comes into my work and how it comes into the larger field. And I kept tripping over the fact that our definition of implementation science has some things in it that we don't do. And I'm going to use the NCI's definition because that's where I do most of my work in cancer, but I think it applies to most aspects of implementation science. And that is that IS is the study of methods to promote the adoption and integration of evidence-based practices, interventions, and policies into routine healthcare and public health settings to improve the impact on population health. But when you look at the literature, our theories, models, frameworks, our methods, our measures, our outcomes, policy is pretty absent. And this is a problem because, as Erika said in the introduction, policies that affect our lives and health are developed and implemented every single day, whether we like it or not. These range from small p policies, the non-governmental kinds of policies, such as those at our workplace that influence whether we can get access to healthy, affordable food when we're at work, whether we can stay home if we're sick or have an infectious disease and protect our own health and protect the health of others. Really, they influence how we care for our children, whether or not we have affordable health insurance as part of our compensation packages, whether we have predictable schedules that can allow us to take care of our children in a healthy and effective and meaningful way. There are also big P policies that are put forth by government. For example, these policies determine, as an example, whether our children's schools are required to provide physical education, how much and when. They determine whether healthy options for food are a part of a requirement for school-based meals. And these specific policies or lack thereof clearly contribute to long-term weight trajectories in kids. So as a result, policies significantly have a clearly significant impact on population health outcomes. Now, a lot of my work has to do with health inequalities and inequities, and policy can definitely eradicate or reinforce systemic structures that lead to inequalities. I think one of the best examples of an effort to use policy to address inequalities is the Affordable Care Act here in the US, which mandates coverage of preventive health services without cost sharing. That has been a very, very important strategy that's been put in place to level the playing field around health inequities. On the other hand, there are lots of examples of systemic reinforcement of structures that produce inequalities through policy. I think a really good example of this is that 30 state Medicaid programs do not cover the costs of comprehensive tobacco treatment. This means that the group with the highest smoking prevalence in those states, that is low-income individuals, has the least access to treatment. Policies also interact with context and are likely to have differential effects across groups based on demographics, socioeconomic status, geography, and culture. So we're just simply not going to be likely to improve health equity if we don't begin to systematically consider the ways in which policies can incorporate evidence-based approaches to reducing inequities and to provide structural supports needed for interventions to have maximal impact. So I would argue there's a huge opportunity for the implementation science field to really think about policy and start to integrate approaches. And I probably should have said at the outset, or maybe this is obvious based on my comments, and I'm not a policy person. I am an intervention developer. I'm a behavioral scientist. But there is this giant hole in what we do. We have this huge toolkit of things that we can do, and policy is one of them, and we have not developed it well. So my own interest is really in seeing the field start to pick this up. So what do we do? Well, the first thing we can do is really build implementation researchers' capacity for policy implementation science, thinking about our theories, models, and frameworks, our measures, our interventions, our implementation strategies, our outcomes. How do those that we have now apply in a policy space? Do we need more theories, models, and frameworks? Goodness, that frightens the heck out of me. We have so many frameworks, but they don't really, they kind of stop at the door of policy. We think a lot about inner context. We don't think much at all about outer context. They don't really address largely the political environment, all these things that are very important in this space. So what do we need to develop new? What do we need to adapt in our approaches? Do our implementation strategies that we use for interventions apply to policy? What are the different outcomes that we need? There's a number of people that have been working on this, and really in the last few years, there's been nice movement. Heather Bullock, Peg Allen, Jonathan Pirtle, Ross Brownson, Jamie Shriekery, Erika Crable, and others. So not meaning to leave anybody out, but this is really nascent, and this is a huge area for our development. We also need to help implementation researchers understand the policy process. This is a space where I think learning from our political science colleagues is really important. We think way too linearly as behavioral scientists, and policy doesn't work that way. So I think a greater focus for us on outer contextual factors, such as the policy and political environment, which are not very often studied in implementation science, is really important. Policy evaluation should also consider implementation outcomes related to social determinants of health and health equity, things such as healthcare access and utilization, environmental justice, and the degree to which those outcomes vary by geography and sociodemographic features. one of the important things in science is trying to study variability. And for better or worse, there's lots of variability in policy implementation. There's lots of opportunity to study these outcomes. And it's particularly important for us to study both intended and unintended consequences. You know, we have a mandate to do no harm. And I think sometimes we assume that we're putting policies in place that are well-intended and even evidence-based, and they're not going to do any harm. And that's not always the case. So that's very important. It's also important to consider the interconnection across policy domains, health, housing, transportation, especially in light of thinking about health equity. There was a really seminal paper written in 2012 that I always talk about when I teach and with my advisees by Reskin. And she talked about the race discrimination system and the interconnected nature of social systems and their influence on inequality, that essentially our social structures operate with compensatory processes that kind of interlock and reinforce structural inequities. So I think this is a space as implementation scientists, as we think about pushing policy on some systems, we have to think about the impact on other systems and how to not get caught in that interlocking system that is going to really block progress. The two last thoughts. One is that we need to think about policy as a way to sustain evidence-based interventions. I think this is a really important area for development. In the work that I do, patient navigation and community health workers are evidence-based strategies that have been shown over and over again to really have an impact on closing care gaps. And we have very little ability to fund these positions. They're largely funded by grants, so they get turned on and off all the time. You lose a lot of the sort of ability to connect with people as people because you have a navigator for one thing and not for another. They're here today, they're not tomorrow. So funding as a policy instrument to sustain that as an evidence-based intervention is really important. And then lastly, I'll just say, I think we as a field really need to recognize the importance of developing collaboration structures that support policy implementation science. I think in the US, we've done a terrible job on this relative to other countries, Australia, the UK, Canada. I think as John has coined this idea of the evidence support systems. And I think this is a space in our implementation science work we really need to take very seriously. So with that, I'll stop there. Thank you.
Thank you so much, Dr. Emmons. Dr. Turner, would you like to share your screen and slides? And while he's getting his slides ready, I'll say, please put your comments, reflections in the chat box, and please feel free to put your questions in the Q&A function, and we will have that moderated open discussion after all three presenters share their information.
Okay, thank you very much, Erika, for the invitation, for organising this workshop, and to the other panelists and indeed the audience for being here. I'm going to present this kind of early review of organisational responses to COVID-19, and by early, I mean that the literature searches were conducted in October of 2020, and it was published in Implementation Science in May 2021. I tend to get a bit of brain fog when I think about the last 2 years and when particular things happen, but just to put a kind of timescale around that. So following that kind of discussion of the paper, I'm then going to discuss some of the implications of the findings in the ongoing and current context of the pandemic as well, particularly the sustainability of some of the early organizational responses that we identified. So the literature review was part of a wider qualitative study that Erika mentioned that I led in Colombia, which was funded by MinCiencias, which is our national Ministry of Science, Technology and Innovation. I would say that it was very much an exploratory study. It was funded for 8 months, which was then extended to 10. And we wanted to understand how rapid change happens in response to a crisis like COVID-19, relative perhaps to longer term planning of change, which I think has been studied in much more detail. So what are the barriers, what are the facilitators to coordinating change in response to a crisis? So in our exploratory study, we conducted 118 interviews online with a variety of national health system stakeholders, and in 3 major cities of Colombia, Bogota, Cali, and Cartagena. So just to give a little bit of context to kind of why we wrote the review, or why we undertook the review in the first place. As everyone knows, a wealth of evidence has emerged on professional and organizational responses to the pandemic. I've put evidence, I think, in scare quotes there, as we've seen lots of ideas that have been shared in response to COVID-19, some of which have been very robustly designed empirical studies. We've also seen case reports, opinion and commentary pieces, and I think quite a lot of anecdotal type contributions as well. And what we want to do in particular as a team was pull out insights from more robustly designed qualitative studies that reported primary empirical findings in order to share evidence that could inform policy and practice in response to COVID-19. Given the limited time available, I won't say too much about the systematic review process. Anyone interested can have a look at the full paper in Implementation Science. But just to note that we reviewed 34 studies in total, 9 of which were actually excluded on quality grounds from our thematic analysis. And I can say a bit more later, if you like, about kind of rigor in these early studies. We used a multi-level approach to analyze the study findings, dividing these into 3 contextual levels: professional, organizational, and local system. And I'm just going to go straight in, I think, to those findings. So at the professional level, many of the studies showed that the burden of responding to COVID-19 fell on the frontline workforce, who either took on an increased workload or perhaps new types of responsibility. In particular, the uncertainty, risks, and changed workload associated with the pandemic reportedly triggered burnout and stress among healthcare workers, frontline staff and managers alike. And this was exacerbated by staff absenteeism and shortage, fear of contagion of the disease, either to patients or to families and communities, and shortages of PPE in some instances. At the organizational level, this is something I've studied quite a bit, COVID-19 was regarded as a catalyst or motivator for implementing new projects and professional teamwork, including things like telemedicine. So for example, in one of the studies we reviewed, a US study of the implementation of video visits or telemedicine in primary care, traditional barriers to implementing service change were reportedly overcome. And the study talks about these being things like provider and staff preferences, different preferences for the nature of services, and ordinary concerns around access and equity for patients. Multiple studies highlighted the urgent need to provide psychological support to healthcare workers facing the pandemic. And in a number of the papers we looked at, there was reference to a more open or engaging management style during the crisis. So leaders, for example, working with closely with frontline staff, acknowledging their value, helping to clarify their new kind of adapted roles, and more generally helping to build trust, belonging, and morale in the context of a very, very difficult environment. And then just finally, at the local system level approaches have been very important to kind of helping to solidify workforce and coordination issues. So we saw a number of interventions at a local system level, maybe a metropolitan area, such as safeguarding working conditions, different agents helping to facilitate inter-organizational cooperation and coordinating the sharing of relevant information and helping to ensure that maybe misinformation was filtered out. At the local system level, there was also some concern from the participants in these studies about the sustainability of new levels of care and services without system-wide support, including, for example, temporary federal funding and the need for the timely review and updating of regulations around service innovations such as telemedicine. I'm gonna, I think, skip over that quotation. And I'm just gonna come on, I think, to the final kind of discussion. So here are some kind of open questions I think that strike me as being important as the pandemic progresses. So The first one is, in what ways have accelerated service innovations been evaluated? So we know that service innovations have been introduced at a pace not typically associated with the healthcare sector. To give a prominent example, have patients, carers and doctors' experiences of telemedicine services been evaluated? How do we know, for example, that such rapid service changes have not contributed to health inequalities, including things like access to technology? Secondly, as the pandemic progresses beyond the emergency planning phase, is the burning platform for action that seem to support new forms of interorganizational cooperation still relevant? Is shared purpose among organizations a legacy of the pandemic, or has it already started to ebb away? I can't answer that right now, but we're at the moment conducting some focus groups in Colombia to see if and why cooperation is being sustained a year or so on from our first round of interviews. And then thirdly, there's been recognition of the critical role of a variety of frontline workers that can often be overlooked in the planning of change processes. But I think there's still an open question about how workforce resilience is being sustained and at what personal cost to frontline health system workers as well as managers. So how is burnout and stress being managed now and indeed being prevented in the future through caring human resource management? And then finally, who needs to be at the table to sustain rigorous and relevant research? So some of the qualitative studies that we reviewed took a team-based approach to allow the rapid collection of qualitative data with the aim of making it more relevant and timely by collecting data quickly. So one US study, for example, reported the completion of 53 interviews in just 4 days through a team of 9 researchers. I think that's quite unusual, but is this type of intensive approach sustainable and applicable to future evaluative research? Do we need any new stakeholder organizations to be involved in research dissemination and implementation processes? Is the existing infrastructure that we have in place in many countries sufficient? Or are we also going to see perhaps a repurposing of existing roles in academia, for example, in order to help with lining up the rhythms of academia and policy and implementation processes? So I think I'll stop there, and yeah, I'll stop there. There's some further reading from our study if anyone's interested. Thank you.
Thank you so much, Dr. Turner. So many exciting questions to explore in our Q&A session. So please do send those chat questions in. I will turn it over now to Dr. Lavis. I'll let you share your screen. Thanks.
Great. Can you see it okay? I'll put it into full mode.
I'll let you know. Now it's in full mode. Thank you.
Great, excellent. So I'm going to slot something that I've been working on for 22 months, which is our work supporting government policymakers and organizational leaders to address COVID-19 into something that has been concerning us, or we've been focused on for the last 10 months, which is the Global Commission on Evidence to Address Societal Challenges. So what I'm going to do is I'm going to use some infographics from the Evidence Commission report, which we just launched yesterday, to talk to you about how we've been doing our work supporting, again, government policymakers and organizational leaders for COVID-19. In the left, you'll see some puzzle pieces, the research system, the evidence implementation system, and the evidence support system. I'm not going to be talking about the evidence implementation piece. I'm going to talk about the explosion of work that has been happening to directly support real-time decision-making with best evidence in incredibly short time constraints in ways that are context-specific and ideally foreground equity. That's where the COVID-19 Evidence Network to Support Decision-Making fits in, and that's what the Evidence Commission picks up. This is my main slide, just to give you a feel for what we've been doing for 22 months, supporting Domestically in Canada, government policymakers and organizational leaders, and through partners in 55 countries, their policymakers and organizational leaders. So one thing we've been trying to do is improve the climate for evidence use, but we don't need to do too much here because I have never seen so much demand for evidence in my entire career focused on this. But we have done a lot of work with partners. There are 55 of them that are involved globally, 40 across Canada. We've been working with a number of working groups. We have a COVID-19 community that we try to support, all focused on trying to find ways to better get evidence into decision making. When it comes to prioritizing and co-producing evidence, we've done a few things. So for probably 16 months, we ran a COVID horizon scanning panel. We would present the panel with briefs about emerging issues. These people were drawn from around the globe, from all different types of decision makers, government, organizations, professional citizens, and we would ask them what are the emerging issues where we need to get ahead of them with best evidence. So when decision makers are ready to make decisions, we have the evidence synthesized. We also spent a huge amount of effort and continue to really try to channel the demand for evidence to the right groups on the supply side. So we have regular meetings with government policymakers in Canada, for example, from across our federal, provincial, and territorial governments to identify their needs, and then find the right groups across the country who can supply an evidence synthesis in a day, in 3 days, in a week, whatever the time constraint is. When it comes to packaging evidence and pushing it to decision makers, we developed both new types of rapid evidence products. So we started developing rapid evidence profiles with turnaround times of anywhere from 4 hours to 3 days, rapid evidence syntheses that would take from 5 to 10 days. But early on in COVID, one of the big innovations that got a lot of traction were living products that got updated regularly. So our living evidence profile on vaccine rollout, for example, got updated every 2 weeks. Our living evidence synthesis on vaccine effectiveness against variants initially got updated every week, and now we're doing it every 2 weeks. When you come to the strategy of what we call facilitating pull, making it easier for decision makers to reach into the evidence world and pull out what they need, we maintain the global inventory of best evidence syntheses. So at last count in our database, we had more than 12,000 evidence syntheses about COVID-19, which covered public health measures, clinical management, health system arrangements, and economic and social responses. But we provide decision makers with the best syntheses for any given question using 3 criteria. And that gets us from 12,000 down to 600 of the best evidence syntheses. And we get them out through global spotlights. So people around the world can find out those new syntheses every 2 weeks. And we also, for our domestic audiences, provided domestic spotlight. So this is how COVID-19 works. We try to improve the climate for evidence use around COVID-19. We work in prioritizing and co-producing evidence with decision makers. We package it and get it to them on incredibly short time constraints, and we make it easy for them to pull it into their decision making when they need it. Interesting, what we normally spend a lot of time on outside of COVID, using approaches like citizen panels and stakeholder dialogues, have not been in huge demand because there are so many other processes that we need to fit into. We don't need to do some of these standalone ones. I'll just point you to a couple of other infographics from the Evidence Commission. This one emphasizing how important it is to combine the best local evidence with the best global evidence. So what has been learned around the world, including how it varies by groups and contexts. So data analytics, modeling, evaluation, behavioral and implementation research, and qualitative insights, absolutely critical to know what's happening on the ground locally. And then ideally we combine it with that global evidence. And that's where COVID-19 has been primarily focused. This is another infographic from the Evidence Commission report. We rate the quality of every evidence synthesis. That gives us one of our 3 criteria for best evidence synthesis. We also look to see whether they provide a great evidence profile when that's appropriate. That's our second criteria. And our third criteria is the recency of the search, because of course, the science moves very, very fast with COVID-19, and a search that was done 4 weeks ago is not going to be as helpful as one that was done in the previous week. This tells you the heartbreaking story of the uneven coverage of evidence syntheses for COVID-19, remarkably few for economic and social responses, some more for health system arrangements, more for public health measures, but the field really dominated by the clinical management reviews that are being done. Also heartbreaking amounts of low and only medium quality evidence syntheses. I mentioned the explosion of living evidence products. I gave you the example of the one that we initially updated every week and now update every 2 weeks, but I think this will become the new normal to support government policymakers and organizational leaders, that we increasingly maintain living evidence products that are updated as the science changes and decision points are faced. I'm almost done. This is another pair of infographics in this case. On the left side, just showing how often other things than best evidence were often seen more frequently by decision makers. Sad amounts of chasing after preprints, lots of squeaky wheel experts, lots of one-off old school expert panels, lots of jurisdictional scans, something that COVID continues to try to address. And then on the forms of evidence, a lot of focus on data analytics, a lot of focus on modeling, a lot of focus on evaluation, sadly not as much focus on behavioral and implementation research, not as much focus on those qualitative insights with the types of studies Simon referred to, and not as much focus on these rigorously produced evidence syntheses and guidelines as we would like. Our view is we really need a balance. So if you're interested in the Evidence Commission report, 24 recommendations, 8 that we deem most important. The ones that are most relevant to what I've been talking about with COVID end are with the evidence support system. It's an example of an approach to support rapid fire decision-making by government policymakers and organizational leaders. The report is now up on our website in all of its forms in English. It will be available in 7 languages. I just saw Igor join who seems to be a Portuguese speaker. So it is available in Portuguese among many other languages. So please do take a look at the report. We hope it's helpful. But my focus today is primarily about how COVID end fits into that work. So back to you, Erika.
Wow, thank you so much. I really appreciate all of our presenters sharing their studies and work with us. I can also say that I have had the the Evidence Commission report came out yesterday, and I have dove into the executive summary, and I can say that the language is highly accessible and usable. So we'll share a link to that because I think a lot of our audience would really enjoy reading that report in full. Let me just share my screen as a reminder to put your questions into the chat box. I'll get us started because we have learned a lot today, and I'm going to try and synthesize some commonalities and messages across these great presentations. I think the first one that really struck me is that, and it's been mentioned in each presentation, but the COVID-19 pandemic has really created a demand for high quality evidence under a short timeline. As Dr. Lavis said, this is unprecedented demand for evidence. And so I'm wondering, given the short timelines and the rapidly changing environment that we're working in, how are researchers like yourselves achieving this in a high quality way? And what suggestions do you have for studying policy implementation or synthesizing evidence for policy development during the rapidly evolving and very uncertain context of the COVID pandemic? I'll let Dr. Lavis respond first, and if others want to jump in, please feel free to.
Well, it kind of feels, Erika, like that's really, all that COVID end has been focused on, this need to figure out how do we adapt approaches that we were doing in the past to this unbelievably unique circumstance. So, you know, political leaders right up to prime ministers and presidents needing evidence and needing it very quickly. And that's on the demand side. And then on the supply side, the science is just moving so fast. So that's why we adapted so many of our processes. So we've for years been presenting, you know, contextualized evidence syntheses to support government policymaking. And we used to think 3 to 30 days was fast, but suddenly we were having to do it in 4 hours to 3 days. So we adapted everything and pivoted very quickly. A lot of us are very burned out from this process, not as much, I'm sure, as frontline healthcare workers are, as Simon's presentation alluded to. And we need to figure out what is a sustainable model going forward. But I think there have been so many innovations from COVID-19 that we now need to figure out which are the ones we want to maintain and how do we systematize them, and then where are the gaps, because many things didn't go well with the COVID evidence response, and that's where we need to start to improve. So to me, I've been in this game for 25 years. I've never felt before such excitement of the potential to really make a difference going forward. And I feel like these next 6 to 12 months are key to lock in the best of what we've seen and to begin to address the many shortfalls in what we've seen.
I was just going to add a slightly different perspective. That the work that Dr. Lavis presented is just spectacular. One of the things that we faced in the US has been the lack of fundamental data on all populations. And so I think as we look forward, trying to think about, you know, where are the data gaps that need to get addressed as you try to roll out evidence-based strategies that will address all populations, it's really critically important.
And I think, yeah, I would just.
Oh, sorry, go ahead, Simon.
Sorry, John. No, I agree. That the work that John's involved in is very spectacular, and I would like to look more into it. I suppose, as an academic, not working directly with such an infrastructure, I suppose personally I found it quite challenging to try to undertake a study, albeit with a team of fantastic researchers, in such a short period of time. So we did 118 interviews in 8 to 10 months, which was a heck of a lot more than anything I'd done in the past. But I think clearly for us to produce evaluative evidence that can be used, we do need to work at a rapid time scale and be prepared to share interim findings as soon as they're available with relevant stakeholders who can help to put them into decision-making and policy. My only concern about that was, as John said, mentioning burnout and so on, how that is sustained and what kind of infrastructures do we need to help us to do that, because there was an intensity, I think, in academia as well as in health systems, health services around the pandemic. But I'm not sure that it hasn't come at a cost to people individually in terms of kind of burnout and stress. So I think we do need a rethinking of the infrastructure needed to support rapid evaluation, for example, in universities.
Thank you. That's so helpful. You know, Dr. Emmons didn't bring it up in this presentation, but has written commentaries about the idea that we need to support and build a policy implementation science ecosystem that would really be leveraged to improve policy responses to COVID-19 and think about how we come together as researchers, policymakers, members of the community who need to have a voice in the development of these evidence-informed policies. Dr. Lavis, you've talked about the existence of evidence support systems, and those are certainly more prevalent in some countries than others. In the US, for example, we do not have a real infrastructure built around delivering evidence and mandating evidence be delivered to government agencies making policies. So I would ask you all, how do we start to create that sort of policy implementation science, evidence synthesis support system? What kind of infrastructure is needed? Can we build it with intangible partnerships and other collaborative processes, or do we really need these sort of centers created to to really be linking government and research.
I have some reactions, but why don't others go first? And Karen, do you want to jump in?
Sure. I mean, I think for me, a big fundamental aspect of that really goes back to what I just said, which is data, and not only collection of the right data, so we understand what the impacts are on all population groups, but the requirements to release that data. So, you know, there've been a lot of issues in my state, Massachusetts, where we're supposed to be collecting, you know, all healthcare data by race and ethnicity, and it was very, very rough in the beginning of the pandemic. Got a little better over time, but only through huge public health pressure on the government. So I think that to me is a really enormous starting point. I think the other aspect to building an ecosystem like this, I think, is what Dr. Lavis has described over, you know, a lifetime of his work, is developing those partnerships that you have sort of at the ready to go to. And I think we often don't do that in implementation. Well, in implementation science, we're getting better and better at developing these kinds of partnerships, but it stops at the door of policy. And so I think thinking about who are the policy and decision-making partners that could come to play. I think in the U.S., certainly governmental officials, but you also have, you know, advocacy groups that are for us here in Massachusetts. Our Massachusetts Public Health Association has been tremendously effective at advocacy in the policy space and the policy implementation space. So who are those partners, and how do you develop relationships with them? Ideally not in a crisis, but in a long-term way, that when those crises appear, you're kind of set and ready to go.
Simon, do you want to jump in?
Yeah, I very much agree with Karen that we need these latent networks or infrastructures in place before a crisis hits, so they can be ramped up as and when necessary in response to crises. I think it does very much differ by country context as well. I think in Colombia, for example, and I'm still relatively new to Colombia, but I think there is potential to perhaps formalize collaborations. I think there was a lot of fantastic collaboration that went through kind of know-who networks within universities and the health system here, and a lot of funding for projects. But I think there perhaps is a lack of infrastructure for building longer term relationships relative to the UK, for example, where we have our collaborative applied research centres in different regions of England, actually, where local research priorities are agreed among universities, local enterprise and the health system. So I think there was an awful lot of fantastic collaborative work. I think there is potential then to build on that and formalize it and have longer term infrastructures to sustain it in the future.
I'll just add two things. One is I was struck in our commission deliberations. We had I hope it's okay that I mention his name, Steve Kern from the Bill and Melinda Gates Foundation, and I'll attribute the comment to him. And he was very forceful on the point that what you don't want to do is like build these models of what things would look like in a crisis, but don't use them regularly. And he had lived through Ebola, a number of other previous crises. And when COVID hit, nobody pulled those off the shelf. And he argued very strongly that we should be using our evidence support systems for the slow burn issues that continue to confront us, inequitable and poorly performing health systems, other things, and then be prepared to scale them up. And so to Karen's point, like work with those partners now so that you can leverage those partnerships later. And the other thing, I agree very much with Simon that it's context specific. And one of the things we're encouraging people to do is look at your local environment, and the things that are going well, try to systematize them, and the gaps, try to fill them. And so in the US, you have the Evidence Act that gives huge attention to data analytics, huge attention to evaluation, but is strangely silent on evidence synthesis and behavioral and implementation research. So the strength is that focus on data analytics and evaluation, but you have to really focus on filling those gaps and developing those mechanisms to get those other forms of evidence. So one of the things that I've learned so much in COVID is none of those forms of evidence can give you the answers on your own. You need the qualitative insights so you know what racialized communities are experiencing with COVID. You need the evidence syntheses. You need the behavioral science. You need all of these pieces coming together if you're really going to have informed policy. So systematize the things going well, but really focus also on addressing those gaps in a context-sensitive way. And to Karen's earlier point, foreground equity. Again, this pandemic has just made all of us so acutely aware of these profound inequities, and we need to bring that lens to all of our approaches going forward.
I wanted to give an example of a colleague of mine who on a smaller scale and outside of the pandemic has done such a beautiful job, I think, of getting those relationships going. Cristina Roberto at Penn has basically been doing for a long time something called strategic science. And so she has basically opened her laboratory to the health department for when they put policies in place to test out different strategies for implementing those policies in an evidence-based way. So if there's a nutrition labeling or sodium labeling, and they have to, the new bill that's passed is you have to label all of your food in a certain way. She can test out for them. This is what happens if you do it this way. This is what happens if you do it that way. Here's how people pay attention. Here's what happens to their behavior. And she has made herself so valuable to those health department partners that she now has relationships that can go in all sorts of different ways. So I think for me, her approach has been a real reminder about how we as scientists in our everyday work can make ourselves useful or not to the people who are going to make decisions in regular times and in crises. So it's just a great model.
Karen, would you be able to put in the chat box her name? That sounds like an amazing.
I absolutely can.
Great.
Yeah, thank you so much for sharing that. That's a great reminder of the utility we can have if we position ourselves correctly as researchers to do more public good. Dr. Ahrens raised a question in the chat. He says the issue of local, so I'll frame this a little bit. Across the presentations and the research that each of our speakers have done, there's the call to sort of say that we need both local evidence and global evidence, and they need to be synthesized and sort of provide context for each other to inform the decision-making of policymakers. And Dr. Ahrens says the issues of local and global evidence is something we hear as a concern of policymakers. That is the will it work here question. How can we best present research evidence in a way that helps to address this issue of integration of local and global evidence? Does anyone want to take that on first? I see Dr. Emmons saying no.
I can just say one. Oh, sorry, Simon.
I'll
go
make
ahead.
a really brief point, but I think one way is to share experiences. I think and debate those experiences. So, for example, in our study where we looked at Bogota, Cali, and Cartagena, those local health systems are very interested in learning from each other and what worked in each of those contexts. And I think rather than just sending a written summary of what worked in each context, actually bringing those actors together to debate that evidence and talk about the particular challenges and opportunities in each context is one way of helping to make it relevant locally. So other aspects relevant locally. Sorry, John.
No, it's so great. I would just add to that excellent point. I mentioned before these stakeholder dialogues, and so these are deliberative processes where you can pre-circulate a summary of what's been learned. But as Simon is saying, that opportunity to talk through, well, what does this mean for us, and how exactly did it work for you, and being able to kind of struggle out loud with how do you combine those local insights with the global evidence, I think is absolutely key. The other thing is for those pre-circulated evidence documents, I think in future we're likely to see them become much more integrative. So coming out of COVID, I now look back and I think of all of the evidence briefs that we've given to our stakeholder dialogue participants, and we weren't covering all the relevant forms of evidence. With hindsight, we were looking at evidence syntheses and we would do key informant interviews and a few other things, but we didn't take a particularly sophisticated behavioral or implementation science lens. We didn't think about the data analytics. So I'd like to think in future we can combine that deliberative approach that Simon mentioned, that I think is absolutely key, with even more integrative products that set the stage for really robust deliberation about what does this mean for us in our context for this issue at this time.
Thank you so much. Gosh, we really need more time for Q&A. This is a really robust discussion, and we're all just so delighted to learn from you. Let's have our last question. Let's sneak one in if we have another minute to answer kind of briefly on a big topic. But we all have talked about the importance of putting equity at the focus of thinking about the way we develop policies, thinking about the way we implement policies and their impact on health equity outcomes. Do you have any thoughts you'd like to share about ways to use co-creation approaches to develop health policies that can have equity in mind at the forefront and be responsive and community engaged? It's a big ask.
I can take a crack at that. I'm actually going to answer it in a little bit of a different way, though it may not satisfy you, but I want to put a plug in for the importance of trust and trust between communities and stakeholders and academics and policymakers. And we've done, again, I'm speaking largely in the US, that we've done a terrible job at this. And what we do as academics is we, sit in our big academic centers and we spend all of our NIH money with our, our outside of our communities. We don't really contribute to the economic security of our communities. And then when we need something, we need you to participate in these trials to develop these vaccines. We come and kind of wag our fingers and say, come on, you guys you're going to benefit from this too, come. And that's just absolutely the wrong approach. And so I just want to put a plug in for, I think as part of this co-creation concept, we've got to start changing the way we invest in communities. Community outreach is over. Community engagement is a little bit over, even though that's, I think, a lot of what most of us do. How do we start to invest in these communities in ways that they can really become partners that can co-create and have co-benefits?
Fabulous.
Any other quick comments from others before we wrap up? I know we're a minute over.
I think Karen's comment was absolutely excellent. We had an indigenous commissioner from the Brazilian Amazon who, gave us insights like Karen just gave us and really shifted a lot of our view about how we just have to do so much better with this stuff. So I 100% agree with Karen's comment.
Yeah, I agree also. And I think just on a kind of technical point of view, in terms of kind of approval for research, getting research ethics approval, unfortunately, it's a lot easier to get approval where you might go and speak to people in the health system, workers, for example. It takes a bit longer often to speak to patients and involve the public in research. And I think if we're able to still do that robustly and in a careful and thoughtful way, but more quickly, I think we would see more of the patients and communities' perspectives coming across in research that's done rapidly.
Absolutely.
Well, thank you all so much. I really appreciated everyone joining us today. We will certainly make this recording available on our YouTube page. I'll also just share some resources from the fantastic forward-thinking work of all of our excellent scholars on this panel today. There are links to some of their recent publications. Please send us your ideas for what you'd like to see in upcoming quarterly policy series. Do you want to learn more about policy dissemination and implementation strategies, hear from decision makers, policy makers about their experience receiving evidence and using different evidence forms, some of the forms that Dr. Lavis highlighted in his work? Please send us your ideas. I think my first idea might be making this session longer because there is so much to learn from you all. I'll ask you to sign in before you go and create the seminar evaluation, and I'll maybe wrap up with a couple ideas. We can't successfully improve health equity without first understanding how to incorporate evidence into policy and ensuring that evidence-based policy implementation efforts can be successfully adopted and sustained. I think that's clear from all of our presenters today. This is true of the COVID-19 pandemic, and it's also true of future health events. So I'll put the charge to everyone in this virtual room to work toward improving the consideration of policy in your research as more than an outer context variable, and in identifying additional strategies that can really help us enhance the use of high quality evidence in policy development processes. Thank you so much for your time today, and just a huge round of applause to our amazing speakers. Thank you so much for the work that you do every day and for sharing your time with us today.
Thanks, everybody. Great meeting you, Simon.
Thank you very
I think
much.
Karen signed off. Thank you.
Cheers. Thanks, everyone.
Thank
Bye-bye.
you.